Alrighty, so today, so we have 2 units left. Okay, we have clinical psychology and we have social psych. Right, so today we are going to start talking about clinical psychology, right? Specifically, uh, psychological disorders. Okay, so this is probably what, like the unit that a lot of you all, some of you all probably signed up for the class, thinking that the class was going to be majority about psychological disorders, and then finding out that it was not. Okay, but that is what we will be talking about: the different categorizations of psychological disorders, and then therapy. All right, so a psychological disorder is any sort of syndrome that is marked by some sort of disturbance in a person's thinking, in their emotions, or in their behaviors. Okay? They're not really called mental disorders anymore. They're more referred to as psychological disorders. So before we get going, I got to give there are a couple of disclaimers that I always give at the beginning of this unit. So this is probably the most sensitive subject that we will talk about in here. We've talked about maybe some awkward things or whatnot, all right, but this is probably the most sensitive subject that we'll talk about. And it's sensitive because a lot of you all are going to have some sort of experience with some of these, whether you have personally dealt with something or somebody that you know has dealt with something. A lot of you all, and obviously everything that we talk about in here is about human behavior, but because we're talking about things that are so incredibly serious and devastating to a person in a family, I know that this can be a little bit of a sensitive subject. So first thing I want to say is, if you ever feel uncomfortable with any of the content of this unit, feel free to, like, if you're on the Zoom call, okay, you can just like mute me or whatnot and post yourself. Right? You don't have to ask permission or anything like that, because I know that this stuff, these topics can be relatively emotional. The other thing is, right, going along with that, right, and I have had students in the past tell this to me, right, if there is a topic here that you know is going to be possibly triggering for you, right? Because maybe you have dealt with it. You don't have to tell me, all right? But like, for instance, I've had students in the past tell me that they just needed to leave when we talk about obsessive compulsive, because talking about OCD can trigger the obsessive thoughts in people with OCD. Okay, so if that is the case, all right, then please, you don't have to let me know or anything. All right, I completely understand. Okay. Um, One of the other things is, and I have had students in the past that this has happened to them as well. You may be dealing with something right now that you don't necessarily know what it is, right? It might be a little bit frightening. Maybe you've tried to go to your parents about it and they have kind of just blown it off, told you to just go run around, ride your bike, you'll be fine. Okay, but there have been students in the past that, as we have talked about things, they have come to me and said, "Hey, this what we were talking about sounds a lot like something that that they are dealing with." Okay, and I just want to let you know, like, if that is the case, all right, you can, I can't, and I'm going to talk more about this here in a second, but like, I am not a therapist. I am not a doctor. I don't even have a master's degree. Okay, I can't diagnose you with anything. I won't try. I won't do any of that. But the one thing that I can do is if you think that you are dealing with something, maybe you haven't been able to get help, I can put you in touch with the right people, okay? Because it's really, really important to understand that psychological disorders is not a weakness, okay? It is not anything to be ashamed of. It is not anything that is your fault, okay? It is also not something that you can deal with on your own, all right? So, very, very important to understand that. And then lastly, okay, and I always like it in this class when students like take what they learned in class and they take it and apply it to their own life. They say, oh, your mom, you're using this parenting style right now or whatnot. That's great. You can't do that with this unit, all right? You cannot even attempt to diagnose anybody with a mental disorder based off of like 7 days of abnormal psychology. Okay, it's what's called intern syndrome. All right, do not try to do it. Don't go around and tell your friends like, "Oh, you're really emotional. I think you have borderline personality disorder," or you really like things clean. You must be obsessive compulsive, right? You cannot do that. It is extremely dangerous to do. It is very harmful, okay? And you don't have the capabilities of doing that. All right, being diagnosed with a mental disorder is a very serious thing. It's very emotional, can be very traumatizing. So do not think that you can go around and do it yourself. Okay? So, anybody got any questions about that before we get going? All right, please ask questions. I know that this is a topic that people have questions about. I am going to try to be as blunt and as I am going to be as straightforward as possible with you all about these. I don't think it benefits anybody to sugarcoat these. It's important to understand what they really are. Okay, so, but any questions that you have about it, please ask. But just know I am going to be as straightforward and as clear cut and lay it out and say this is what this is. All right, so we all have bad days, right? But not all of us are depressed. Okay? We all get nervous sometimes, but not all of us have generalized anxiety disorder. Right? Does anybody know what are some of the differences? What is the difference between feeling depressed and being clinically depressed? All right, okay. There does need to be a diagnosis there. Anybody know what part of the criteria is for there to be a diagnosis of clinical depression? Anyone? No? Usually somebody knows this. Okay. For clinical depression, it has to be persistently low mood for at least 2 weeks. Okay, but for it to be a mental disorder, right, or a psychological disorder, sorry, okay, it has to interfere with your quality of life. Okay? If you're a neat freak, but it doesn't get in the way of you like just doing things on a daily basis, that's not obsessive. Okay? If you're just kind of sad, but it doesn't get, but you're like, you know what, I'm in a bad mood, but I'm still going to go out and I'm going to do my stuff and whatnot. That's not clinical depression. Okay? If you're just nervous, but you're still able to function, all right, that's not generalized anxiety. All right, it has to interfere with it has to interfere with your daily life. Now, psychological disorders are unbelievably difficult to diagnose, okay? Because they can be very mild, all the way to extreme. They are a spectrum. All of them are a spectrum. And, they look different at different ages as well. Young people generally experience psychological disorders more intensely than older people do. Okay? So generally, as you get older, we do what's called regress to the mean. Meaning, as we get older, we kind of go back to average, even if at a younger age you suffer from something. Okay, so, that is one of the reasons why these are so difficult to diagnose. Now, a couple of the criteria, and it doesn't have to have all of these. That's the fit somewhere in there, right? It could be distressing to the individual, meaning it causes some sort of like pain, psychologically or physically, to the person. If somebody is having auditory hallucinations, type associated with schizophrenia, right, and those auditory hallucinations are telling them to hurt themselves or hurt somebody else, right, that's going to be distressing to the person. It can be atypical, deviating from cultural means or norms. Has anybody ever watched that show? Yeah, I guess it's my strange addiction. Okay, right? If somebody has an addiction to eating their own hair, right? At least in Western culture, that would deviate from cultural norms. But then also, it can go in different, like if somebody is defecating on the side of the road, right? Here, you'd say that would be atypical for our culture, but in other cultures, going to the bathroom in public on the side of the road, right, could be perfectly acceptable. So it deviates from cultural norms. Is it maladaptive? Meaning it goes against adaptation. Meaning it hurts us in some way. Borderline personality disorder. It's characterized by extreme mood swings, and people who have it have a very, very difficult time in relationships. They can be very, very jealous, right, but also very untrusting. Right? That's maladaptive. It hurts their relationships with other people. Is it disturbing to others? Somebody in a full psychotic break may not be in touch with reality enough to realize that them running around in the middle of the street, flapping their arms, screaming at people is disturbing, but it would be disturbing to other people to see that. And then, is it possibly unjustifiable or irrational? If I think that if I leave a room, and I think before I leave any room, I have to turn the lights on and off 7 times, and if I don't do that, then something horrible is going to happen to my family. Okay, that is irrational. Okay, are psychological disorders genetic at all? Yes. Just like we're going to talk about that. There are a mixture of things, but different ones have different genetic components. But ones like depression, anxiety, and schizophrenia do have a strong genetic component. All right, so any questions on that? Okay. All right, so this isn't very important, but early theories on disorders. They originally thought that it was like spirits trying to get out. One of the ways they tried to treat mental disorders was a technique called trephining, which was basically using this large corkscrew type thing, and they drill a hole into your skull, thinking that it would let the demons out. In reality, it just killed people or gave them brain damage. Okay? That's a picture of the skull that had been trephined right there. And something we'll talk more about later, but in the 1930s, they developed the technique of the frontal lobotomy, which is where they would get a long nail and put it right in the eye socket, and hammer it in, right up through the bottom of the skull, into the frontal lobe, into the prefrontal cortex. You swirl it around a little bit, cut all those neural connections, and boom. People that were psychotic were no longer psychotic because they didn't have any personality at all anymore. Okay? It basically just took away their entire sense of self. They did it for psychosis. They also did it with kids with ADHD. They did it for about 25 years or so until they started killing a bunch of people. We'll talk more about that later, though. The asylum system, up until the 1950s, people that were psychologically disordered, specifically people that had psychosis, there's really no way to treat them. And so instead of trying to treat them, they just essentially locked them up. They just put them in an asylum and they just kind of died there. Does anybody know the name of the person? Can I get cameras on, please, guys? Anybody know the name of the person that did a lot of the sanitarium reform in the years after the Civil War? He was a union nurse. I know y'all learned this in U.S. history. Anybody know what her name was? Dorothea Dix, the person that did a lot of the sanitarium reform. Because after the Civil War, they started seeing so many more cases of what we now know as PTSD. Right? And then in the 1950s, you can see 1950s had about 500,000 people in asylums. Which were just places, when they went to an asylum, they didn't leave an asylum. And then in 1955 came the discovery of the first antipsychotic drug, the drug called Thorazine. Antipsychotics are used to treat disorders like schizophrenia, the manic phase of bipolar disorder, antisocial personality disorder, things like that. Disorders in which you lose touch with reality. Right? Thorazine and others like that, chlorpromazine, help with that. And as you can see, that led to a massive decrease in the amount of people in mental hospitals. Okay, because people were now able to take Thorazine and it controlled their symptoms, and they were able to survive. They were able to function sometimes somewhat normally. About a quarter of people with schizophrenia can function totally normally with medication. And this was the beginning of what is called the medical model. The medical model looks at mental disorders as medical issues, just like we would cancer or diabetes or anything like that. And therefore, because they are medical issues, they have biological causes, and they can be treated with medicine. Now, that's true. A lot of them can be treated with medicine. Most of them do have some sort of biological basis. Okay, and because of this, it led to that people were put in hospitals rather than asylums and went treated. But this also led to this idea of the single cause. Right? Does anybody have a guess what that is? What is the myth of the single cause? Anybody have a guess? exactly. Yep. That schizophrenia is caused by too high levels of dopamine. Depression is caused by low levels of serotonin. Anxiety is caused by low levels of glutamate, of GABA. Okay, and so on and so forth. Which we should know at this point, nothing in this class has one single cause. Right? Multiple causes, or actually, it's referred to it now as multiple causation. All right, gonna do one more slide. So now we look at mental disorders much in the same way that we look at personality. Okay, because mental disorders a lot of times are a part of our personality. Right? As through the lens of what is called the biopsychosocial model. The biopsychosocial model says that mental disorders are a product of interlocking factors. That they're a combination of biological influence, genes, brain chemistry, all those different things, psychological influences, right? This would be like cognition and how we think, and cultural influence and social influences and environmental influence. It's all these kind of things, just like we talked about with reciprocal determinism, our personality being partially response to the environment, partially learned behavior, partially how we think, all these things. Okay, psychological disorders are viewed in the same way. Now, one of the even newer models that goes along with this, it's part of it, is what is called the diathesis, either diathesis or diathesis. I'm not sure which one. The diathesis stress model. It says that mental disorders are a combination of our own individual characteristics, our genetics, our thought patterns, whatnot, and then different environmental stresses. And how we deal with these stressors. And a lot of the research on this deals with what is called epigenetics, which is how environments affect genes. So we know now that genes can be turned on or off depending on the environment that we are. Certain environments can trigger certain. If you are genetically predisposed to something, certain environments can trigger that gene to activate. I'll give you an example, a possible example. It's tough to tell now, but so schizophrenia is a highly genetic disorder. Okay, that if you are your chances of developing schizophrenia go up by, I can't remember by how much, 50% or so, I can't remember, but if you are genetically predisposed to it, meaning if you have schizophrenia in your family. But that doesn't mean that you will develop it. It just means that maybe that under the right circumstances, possibly. And so my best friend in high school, his name was Dave. Okay, and Dave in high school, normal, completely normal guy, a little bit eccentric, but he was like a really good musician, blah, blah. And Dave had schizophrenia in his family. All right, his aunt was schizophrenic, which means he was genetically predisposed to it. Now, he showed absolutely no signs of it until around the age of 19 or so, that is the normal age for onset for schizophrenia, late teens, early 20s. And so he showed until he went to college. Now, one of the other things that they know about schizophrenia is that if you are genetically predisposed and you start using hallucinogenic drugs, such as marijuana, mushrooms, LSD, things like that, those hallucinogenic drugs can trigger that gene to turn on. And Dave had never done anything, never smoked weed or anything before he went to college. Went to college, started smoking a lot of weed, right, and started doing a lot of LSD, right, and all of a sudden he started it took a couple of years, but he had a full-on psychotic break. Okay, he's not alive anymore, unfortunately, but I'll tell you more about him when we get to schizophrenia. But there's no way to know right now. Like, all right, was he gonna have schizophrenia anyways, or could it have been due to the fact that he was predisposed to it, and then also he had the stressor of using hallucinogens? So, possible to know right now, but there is that question. Okay, all right. Does anybody have any questions about any of that?